Professor Rayner.
My Lady, this is the opening statement of the National Care Forum, and I am its Chief Executive. The National Care Forum is the membership body for not-for-profit care and support providers in England, who provide a diversity of services across all age groups. Including residential and nursing homes, supported living, extra care housing, domiciliary care and day services to hundreds and thousands of people. The National Care Forum dedicated significant time and resources throughout the pandemic to support and represent the experience of its members, highlighting the operational realities of delivering social care and support and how they related to government guidance, engaging with the government and other stakeholders and advocating on members' behalf as they battled COVID-19. My Lady, before I go further, I want to acknowledge the loss of life of all those with a connection to adult social care, including people accessing care and support and care workers. Care workers, people accessing care and support, their families and loved ones were all deeply impacted, and in addition, many continue to grapple with ill health and the legacy of those years. In this opening statement, I want to give voice to the myriad of ways in which social care providers supported communities and their most vulnerable citizens to ensure their care and support needs were met. In the face of huge challenges, I want to highlight the isolation and systemic misunderstanding and disadvantage that the adult social care sector experienced repeatedly throughout the pandemic. I also want to be clear that the UK government did, in fact, receive a huge volume of information and expertise that NCF and our members provided repeatedly directly from the front line of delivery, which highlighted in real time the risks facing social care and support services and what was needed to minimise, where possible, their impact. We are also concerned that much of what the inquiry has heard to date does not adequately recognise the skill, professionalism and dedication of the social care workforce, particularly in the face of the pandemic. The response of adult social care and support providers in the face of limited resources, limited support from wider system partners and increasing restrictions was only possible because the people who make up social care, the frontline staff, the managers, the support team, the senior leaders, alongside many others, all came together to find a way through and deliver care and support. Many took on jobs and activities they wouldn't normally do. Everyone was working together to ensure that quality care and support was maintained. And they did this because social care is inherently relational. It is about supporting people. They did this because they care. This is vitally important for the inquiry to hear. My Lady, I want to use the remainder of the ongoing statement to outline significant concerns we had with regard to the impact of the pandemic on the adult social care and support sector and the key decisions made by the UK government during that period which made the response more difficult. These are more fully laid out in my witness statement. I first want to highlight pre-pandemic preparedness. While outside the timescales of this module, it is important for the inquiry to remember that social care went into the pandemic ill-prepared, with over 100,000 staff vacancies, a precarious financial situation following a decade of austerity, and the lack of any investment by the state in digital, data and physical infrastructure. The risks around capacity were highlighted as urgent as recently as 2016 during exercise Cygnus. Second, throughout the pandemic response, there was a concerning lack of understanding of adult social care by policymakers, leading to an unhelpfully narrow public, policy and resource focus on care homes for older people, with little consideration of the breadth and diversity of care and support settings and services, which all needed a help and start from the start of the pandemic. As a direct consequence, guidance and policy created during the pandemic were marked by a lack of understanding of the diversity of adult social care and support services and the people using those services. The flow and communication of guidance from government and key stakeholders were poor and chaotic, and this was exacerbated by unclear chains of command, particularly the role of national versus local decision makers. Changes in the guidance itself were often communicated last minute, sometimes over bank holidays and often late on Friday nights. Changes in the policy relating to key elements of social care and support were often communicated by press release or the daily briefings. with this landing sometimes days and occasionally weeks before the final guidance was issued, leading to a mismatch between public understanding of the situation and the guidance that care and support providers were being instructed to follow. All organisations had to grapple with multiple, interdependent, sometimes contradictory pieces of guidance which were updated at different times. This was particularly challenging for smaller providers who form the bulk of the adult social care sector. I want to move on to the disregard shown for the people accessing or working in care and support from government and the wider health system in relation to key areas including testing, PPE, vaccination, accessing of community and specialist health services, and many other areas. The advice of social care experts was often ignored or marginalised. This is in spite of repeatedly highlighting key issues including the breadth and depth of social care and support, the need to ensure that guidance was possible to implement for small organisations, the inability to access community health services and the impact on those receiving care and support and the care workforce, the inappropriateness of blanket guidance around areas such as isolating people living with dementia or other complex needs, the need to balance the risk of harm from COVID through enabling visiting with the risks of harm resulting from separation and isolation from loved ones, and many more key issues. To support these perspectives, we gathered and shared rapid evidence, sought out independent expertise and provided examples of how to mitigate risks, always building on the critical stream of information we received day in, day out from the front line through our close work with members. I also want to draw the inquiry's attention to the funding of social care during the pandemic. The drip feeding of funding support was unhelpful, insufficient, inefficient and bureaucratic. Whilst all funding was greatly needed, it came after very significant advocacy from the sector and was provided only in the form of emergency, short-term, time-limited funding, which was never sufficient to meet the publicly described need. This short-termism meant providers were unable to put long-term protective measures in place. My next point relates to the collection and use of data, which was highly problematic throughout the pandemic for adult social care. Infrastructure around data was lacking before the pandemic. And during the pandemic, data collected from providers via Capacity Tracker was used to meet policy aims, such as the freeing up of hospital beds, rather than to prioritise resources for providers who were including data that showcased their lack of PPE and shortages of staffing. In addition, collective data received by government in relation to new variants of data that would have flagged the need for additional capacity was not shared with providers. It is important to recognise that staffing and capacity became increasingly difficult due to the direct impact of the pandemic, with organisations dealing with rapid increases in vacancies and sickness levels. This was compounded by guidance which required isolation but came without sufficient financial support. In addition, specific cross-sector recommendations relating to the social care workforce in the summer of 2020 were not adequately addressed by the government. Finally, the pandemic has revealed the deep-seated inequalities in our health and social care system. Due to its composition and the people who access care and support, this is a sector where several inequalities intersect along ethnic, gender, age, disability and socio-economic lines. My lady, as outlined earlier, this will only change if the apparatus of government actually understands and values the people who work in social care and the lives of people who receive care and support. In conclusion, the points I have outlined can be summed up in 3 ways. Number 1, social care was overlooked in key decision-making moments. Number 2, social care was misunderstood by decision makers and the wider public. Social care is a diverse, interconnected system of care and support services for all ages, with a workforce larger than the NHS. Number 3, social care was disadvantaged, especially in comparison to the NHS. The focus of decision-making appeared to be narrowly on protecting NHS hospital capacity rather than citizens in all communities. Our participation in the inquiry is motivated by our commitment to ensuring that everyone involved in care and support does not have to go through this experience again. It is essential that clear operational and implementational lessons are learned and applied across pandemic planning, preparedness and response. Those are our opening submissions, my lady.
Thank you very much indeed.